Today I'm going to be talking about a subject which is very common to us hand surgeons, and not a day goes by when I'm seeing patients that several do not present with the problems of osteoarthritis either affecting their hand or their wrist. We separate osteoarthritis into two major categories, primary and secondary. Primary indicates that these are patients who have no other underlying disease or inciting event that caused the degeneration of their articular cartilage. These frequently are women of middle age and often have a family history of similar osteoarthritis. There is some indication that mechanical forces can aggravate the osteoarthritis. In point of fact, there was a study done in Japan of women who worked in a school system, and those who used their hands for active use in the kitchen, such as cooking, had much more arthritis than those who just served the food or were acting as the cashiers. Primary osteoarthritis of the wrist rarely affects the radiocarpal joint. When you see arthritis affecting the radiocarpal joint, you should think of secondary rather than primary arthritis, especially if the person has a history of inflammatory disease. Primary osteoarthritis in the wrist frequently affects the STT joint and the piezotriquetral joint. In the hand, which is actually more common in the wrist, the disorder affects the basal joint, which is sometimes called the CMC joint, to some degree more than the MP joint of the thumb, as well as affecting the finger MCP joints occasionally, but very commonly the interphalangeal joints, which are called Bouchard's nodes when they affect the PIP joint, and Heberden's nodes when they affect the distal phalangeal joint. Here are some x-rays indicating typical primary osteoarthritis. The basal joint is affected between the metacarpal and the trapezium. The interphalangeal joint affecting both the PIP joint in the upper right and the distal joint in the lower left, and the slide on the right indicating primary arthritis of the scaphotrapezial joint. The radiological findings which are common to all these are loss of the joint space, osteophytes, and sclerosis, and sometimes angulation and deformity. There are some patients, especially affecting the PIP and sometimes the DIP joint, who by radiological evaluation have a lot of destructive changes. This has been called the erosive osteoarthritis and has some similarities of inflammatory disease like rheumatoid, but these patients are seronegative. Secondary osteoarthritis is the type in which there is some underlying cause. These can be fractures, especially affecting the distal radius, infection, and metabolic diseases, especially things such as gout, calcium pyrophosphate, which is called pseudogout, and hemochromatosis, especially those that affect the MP joints of the fingers. Patients with diabetes also seem to be at greater risk for developing secondary osteoarthritis, and on occasion things such as frostbite will after a while produce some degenerative changes of the joints which were in the region of the frost. When we see patients who have radiocarpal arthritis, we need to make sure that we understand whether or not there's been some evidence of a fracture of the distal radius, fractures of the scaphoid, which has been called the SNAC wrist, meaning scapho non-union advanced collapse, ligamentous injuries, especially those affecting the scaphoid, which has been called the SLAC wrist. And when we evaluate patients who have either the SNAC or the SLAC wrist, we need to be careful in determining whether or not the arthritis affects only the radiocarpal joint or whether it affects the midcarpal joint. The staging is important because it leads to an understanding of appropriate treatment. Kienbock's disease, gout, calcium pyrophosphate disease, and infection are other reasons for producing secondary arthritis of the radiocarpal joint. Regardless of the cause of the osteoarthritis, whether it's affecting the wrist or the digits, it's important to inform the patient as to the reason for their disability. As far as treatment is concerned, most of these patients can be treated non-surgically with oral medication, whether it's NSAIDs or acetaminophen for pain relief. Injections of glucosamine and cortisone produce temporary effect, but rarely produce long-term benefit. Certainly, a hand therapist would be of value in teaching patients to adapt to their problems and can provide splinting and sometimes provide therapy if there's been an exacerbation rather than long-term symptoms. As far as the surgery concerning the wrist is concerned, the major goal here is to relieve people of their pain. It's important to take into consideration the patient's age, their functional needs, and then the question is, if we're going to try to preserve mobility, which joints are arthritic and which joints can be preserved, because a full wrist fusion, such as sometimes is necessary, is not always indicated if some of the joints are arthritic and others. An operation which I've found very, very effective and useful in patients who have arthritis of the wrist, regardless of the cause, is a neurectomy. The two nerves which are usually indicated for treatment would be the terminal branches of the anterior and posterior interosseous nerves. We tend to think of the AIN and PIN as being motor nerves, but in point of fact, their terminal branches are into the capsule of the wrist joint. I prefer to do a diagnostic lidocaine injection, which is simply done in the office. This is done by inserting a needle in the interosseous space between the distal radius and distal ulna. I use a 21 gauge needle. The needle is inserted just to the point of feeling some resistance, which means that you're now just sitting on top of the interosseous membrane, and then I inject 3 cc's of 1% lidocaine. The needle is advanced just a little bit. You'll feel it going through the interosseous membrane. I aspirate to make sure I'm not involving myself in one of these small arteries, which frequently coexist next to the AIN, and then inject another 3 cc's of lidocaine. Prior to the injection, I have the patient try to lift their body off a chair and to try to have the patient remember how much pain they're having when they do this single-handed push-up. Then I wait about 10 minutes and ask the patient to do the same maneuver and see whether or not there's been substantial release of their pain. If there is, then I think a simple operation such as a denervation makes a lot of sense for patients, because it provides good relief of pain in most patients. The recovery is very simple. There's no immobilization, no need for therapy, and of course it leaves all the doors open to more involved operations. If the neurectomy or the AIN injections are not successful, then there are many operations which are available in treating osteoarthritis of the wrist. The most popular probably is proximal row carpectomy. This involves removing of the scaphoid, the lunate, and the triquetrum. This is done in the presence of arthritis, but not severe degeneration of the capitate, because success of this operation depends upon a good articulation between the distal radius and the capitate. There are many patients, however, who do have some capitate erosion, who undergo proximal carpectomy with good results, these patients frequently benefit from interposing the dorsal wrist capsule between the capitate and the radius. Those patients who undergo proximal carpectomy are usually immobilized for approximately 3 weeks, and then range of motion is begun with a removable splint. It used to be typical to immobilize the wrist for this period of time with a Kirschner wire. This is less commonly used because there's been a number of reports of problems related to infection, irritation of the radial sensory nerve. I would suggest immobilization with the K-wire does make sense if after doing the proximal carpectomy you find that the wrist remains somewhat lax in the operating room because of laxity of the scaphocapitate ligament, which should be preserved during the surgery, and the hope would be that temporary immobilization with the Kirschner wire would lead to improvement in the stability. Again, in patients who have arthritis affecting the midcarpal joint, where there's significant erosion of the proximal capitate, where the feeling would be that proximal row carpectomy would not be a successful operation, then a midcarpal arthrodesis could be considered. There are many varieties of methods of doing this procedure. Some involve just excision of the scaphoid and four-corner fusion. Other surgeons prefer to remove not only the scaphoid but the the triquetrum, which would improve radial and ulnar motion. Most surgeons would prefer to fuse the lunate, capitate, triquetrum, and the hamate, but there are many reports of just fusing the lunate and capitate with similar results. It is important, however, to make sure that at the time of the four-corner fusion, if there is malalignment of the lunate, which frequently in an arthritic wrist related to scapholunate disease or non-union of the scaphoid, leaves the lunate in an extended position. And it is unfortunate that sometimes the fusion is done with the lunate in an extended position, which does not lead to predictably good results. There is some discussion about in patients who have a good midcarpal joint whether or not they should have a four-corner fusion or proximal row carpectomy. There's been some information that younger patients probably do better with a four-corner fusion because it gives them somewhat better strength, but there is not significant evidence to believe that this is necessarily true. The range of motion seems to be about the same. The strength and pain relief seems to be about the same. The problem with midcarpal fusions, obviously, is that it requires good carpentry, good fixation, and there's always a concern that the implants may need to be removed or there may be non-union of the attempted arthritis. If, however, there is severe arthritis involving both the radiocarpal and the midcarpal joint, or if there's been a failure of proximal row carpectomy or midcarpal fusion, then full wrist fusion is a very effective operation in relieving pain, but obviously at the expense of motion. Implant arthroplasty, which was probably very valuable for the rheumatoid, seems to be less effective in the patient with osteoarthritis. This is because these patients have more active use, they have higher demand, and there tends to be significant loosening of the implants and dislocation, so that the implant arthroplasty failure rate, even in modern technique, is still approximately 50%. A common form of arthritis involves the scaphotrapezial joint. I'm not sure I understand why this happens, because in patients who have scapholunate advanced collapse, where the scaphoid flexes, and they may get arthritis of the radiocarpal joint, you would expect that they would also get arthritis of the scaphotrapezial trapezoid joint as the scaphoid goes into flexion, but this is rarely a problem. So I'm somewhat mystified as to why this happens. In patients who need surgery for STT arthritis, my preference is to excise the distal scaphoid and to interpose a piece of the flexor carpi radialis tendon. This promotes early recovery of motion, relieves them of their pain. However, if the patient does have evidence of scaphoid flexion, this may be aggravated by scaphoid excision, and therefore this would be a situation where scaphotrapezial trapezoid fusion would be better, be a better choice. The problem with the STT fusion is that, again, like the four-corner fusion, requires good carpentry, good alignment, and good fixation. The most common form of osteoarthritis affects the basal joint of the thumb. Cadaver studies show that the majority of women at the time of their death, in point of fact, have basal joint arthritis of their thumb. There's been some question as to why women are predisposed. This obviously usually is not related to physical activity. Otherwise, you would expect people who are involved in the heavy construction trade would have a lot of basal joint arthritis. There is a hormone called relaxin, which exists both in men and women. In women, this is important during pregnancy to allow the pelvis to relax, to allow delivery. Men do have relaxin. However, this relaxin doesn't seem to be as effective. In women, it is thought that the presence of this relaxin causes laxity of joints and predisposes to subluxation of the thumb metacarpal on the trapezium. Patients with basal joint arthritis may have deformity, but they may have no symptoms. It is important when evaluating these patients to look at the amount of arthritis that exists. In the early stages, the joint may have no evidence of degeneration of cartilage, but the joint may be lax and unstable. In stage 2, the joint space is reduced between the metacarpal and the trapezium, but there's still some joint space present. In stage 3, the joint space is completely absent, and in stage 4, there's arthritis not only between the metacarpal and the trapezium, but the trapezium and the scaphoid. It is also very important in evaluating patients with basal joint arthritis is to evaluate the metacarpal phalangeal joint. Especially in patients who have subluxation of the metacarpal and adduction of the metacarpal, the MP joint may go into a hyperextension to accommodate for the loss of mobility of the carpometacarpal joint. If you're going to treat these patients surgically, it is important, therefore, to evaluate not only the joint space between the metacarpal and the trapezium, but between the trapezium and the scaphoid, and also the thumb MP. There appears to be some evidence that in those patients who have instability of the basal joint, that correction of this instability prior to the development of arthritis will be a preventative operation. On the X-ray on the upper right, you'll see an X-ray in which stress is placed between the tips of the two thumbs, and you can see that the metacarpal with this stress X-ray slides radially out of the saddle joint of the trapezium. There's been some discussion about which ligaments are the most important in stabilizing the basal joint of the thumb. Pellegrini initially said it was the volar beak ligament, and now we understand that it's actually the dorsal ligament which is most important. However, I would posit that in those patients who have significant instability, there's probably laxity of both joints. Both ligaments. Littler and Eaton described a very useful operation for the unstable thumb metacarpal carpal joint, which utilizes a strip of the flexor carpi radialis. They also demonstrated that in those patients who have symptomatic laxity, that if you stabilize the joint with this operation, that progression of arthritis will probably not occur. Obviously, most patients with basal joint arthritis do not need surgery. They can be treated with some sort of support, whether it's rigid or elastic, analgesics, and if they have early basal joint arthritis, injections of cortisone can be very, very effective. These can be repeated at intervals, but at some point in time it may be necessary to consider surgery if the symptoms are persistent and disabling. When performing basal joint surgery, almost all operations today include removal of the trapezium. It is important after the trapezium has been removed to determine whether or not there is arthritis between the trapezoid and the scaphoid. And if there is, then some removal of that joint surface should be done in order to relieve the patient of their pain. In addition to trapezial excision, which was originally described by a German surgeon by the name of Jervis, there are many other options which are available in terms of stabilizing the thumb metacarpal. One is to insert a Kirschner wire into the metacarpal and stabilizing the metacarpal to the scaphoid. I do this because it makes it easy for the patient to use a removable splint beginning a week or so after the surgery, and the pin is removed at approximately 3 weeks. I don't think that the K-wire is necessarily an obligation, but it just gives me a bit peace of mind. Interposition of some soft tissue, such as a piece of the palmaris or flexor carpi radialis, is also popular because there are some patients in whom, after simple trapeziectomy, the metacarpal subsides and is rubbing against the scaphoid, preventing good recovery. This is a relatively uncommon problem, but again, it's a simple addition to the operation and is a very popular addition to the trapezial excision. Ligament reconstruction, whether it's with the flexor carpi radialis in a method similar to described by Eaton and Littler, or using the Thompson approach, utilizing a strip of the abductor pollicis longus, is, in my estimation, not needed to be done routinely, although there are a lot of surgeons who find this is useful, but no studies have ever been shown that there's any significant advantage to doing it. Artificial stabilizers such as the tightrope have gained some popularity. The problem with them, I think, is that they're expensive. They've never been shown to be of real advantage, and there have been some technical problems, either irritation from the fiber band itself or the fixation method. If there is a patient whose major demand is strength, then fusion of the metacarpal to the trapezium is an excellent consideration, especially in patients who are such as manual workers. The problem with this is that it does diminish some of their flexibility and may aggravate underlying scaphotrapezial arthritis. Artificial implants have been used. They have been rarely effective, partly because there are no ligaments to keep the implant in place, or there has been foreign body reaction to these implants. A final operation which I'd like to mention is simple denervation. This is an operation similar to that done for the wrist joint, in which several branches of nerves, such as the palmar cutaneous branch, the lateral cutaneous branch of the forearm, and the radial nerve, which have innervation into the wrist capsule, are found to be useful in terms of denervation. This provides early recovery and certainly does not burn any bridges. Again, I'd like to reiterate my concept about patients who have hyperextension of the MP joint. If this is rather mild, a few degrees, then this probably will spontaneously reverse once the metacarpal is stabilized. If, however, the MP joint hyperextension is 30 degrees or so, then a tightening of the lax volar plate should be done. Temporarily stabilizing the joint with a K-wire does nothing to improve the stability of the volar plate, and I don't think is a useful procedure. If, however, there is marked hyperextension, or if there's evidence of MP joint arthritis, then obviously fusion, as you see in the bottom picture, makes the most sense. Finger MP joint arthritis is relatively uncommon. It seems to affect the index and middle much more so than the ring and small, and may be a form of hemochromatosis. If non-surgical management is not effective, then surgery could be considered. In general, patients would prefer to preserve mobility, so implant arthroplasty is the most common. If, however, the index finger demonstrates significant laxity of the radiocollateral ligament, if it's a person who does a lot of pinching and gripping, then fusion of the MP joint may be preferable to implant arthroplasty. Unlike patients who have rheumatoid disease, the collateral ligaments are usually intact. In this situation, it would be important to preserve the collateral ligaments on the radial side, especially the index finger, but both collateral ligaments can usually be preserved at the time of the implant insertion. The advantage to preserving the collateral ligaments is that it allows early mobilization, and in the upper right you see a patient whose surgery was done 1 week ago and is treated with early range of motion, buddy taping the index finger to the unaffected middle finger. My preference still is to use silastic. I think that there is no evidence to believe that more advanced implants such as pyrocarbon, the metal plastic, and cemented implants are significantly better than silastic. As far as the PIP joint is concerned, again, like the thumb, there are many patients who present with complaints of deformity and swelling who have good function and relatively acceptable pain. It always amazes me how these patients have such little pain in spite of the fact that they have significant deformity and gross destruction on their x-rays. If, however, the patient does require surgery, then the choice would be between implant arthroplasty and fusion. Again, like the finger MP joint, most patients with PIP arthritis would prefer to preserve their mobility. The implant of choice, in my estimation, is still silastic, because pyrocarbon and the metal plastic implants have a greater tendency, as I'll show you later, to erode or to fracture. In an article not too long ago in the Journal of Hand Surgery, it was found that patients who had implant arthroplasty utilizing a pyrocarbon implant into the PIP joint had a 34-degree reoperation rate, a level to me which seems very, very unacceptable. In terms of the surgical approach to the PIP joint when doing an arthroplasty, traditionally the approach was done from a dorsal operation. However, there are two other approaches which I think are important to consider. In addition to the dorsal operation, one would be the lateral and one would be volar. My preference is to do a lateral approach. This way we do not have to operate on the extensor tendon nor around the volar structures. This can be done from a mid-axial approach. A collateral ligament is reflected, leaving it attached to the base of the proximal phalanx. The condyle of the proximal phalanx can then be removed. The joint can be shotgunned, reamed, and the implant inserted. Then the collateral ligament can be reattached. If the collateral ligaments are of good condition, I would prefer to release the least important collateral ligaments, such as on the ulnar side of the index or middle. But if there is some laxity of the collateral ligament due to joint deformity, then I will release the collateral ligament on the lax side and then tighten it after the implant has been inserted. If, however, there's evidence of laxity of the extensor mechanism, as you might see in a patient who has a boutonniere type deformity, then a dorsal approach makes sense because you want to correct the laxity or incompetence of the extensor mechanism. And in this kind of situation, the incision would be dorsal. The central slip could be reflected, as could be the lateral band, the implant inserted, and then the lateral bands tightened distal to the level of the PIB joint and the central slip reattached. If the patient, however, has the opposite problem, a swan neck type deformity, with hyperextensibility of the PIP joint, then something must be done to regain competence of the volar structures to deal with the volar laxity. And in this situation, a volar incision would make sense because at the time of surgery, the volar plate could be reapproximated, or a slip of the FDS could be used to reconstruct the lax volar plate. If this is not done and the implant is inserted either from the dorsal or lateral side, then the recurrence of the swan neck deformity will be a significant consideration. The method of post-operative treatment obviously is different for these two techniques. For the lateral technique, where the extensor and the flexor are unaffected during the surgery, then early mobilization without much protection can be done. If, however, the insertion of the implant is done from the dorsal side, then a protective splint must be done, allowing motion after approximately 3 weeks to allow the extensor to become competent. If, however, you're doing it from the volar side, then you may need an extension block splint, allowing flexion but preventing hyperextension to allow the volar structures to heal. This is a patient after undergoing scholastic implant arthroplasty of the left and right ring fingers with good flexibility, good recovery of pain. If, however, the joints are grossly unstable and it is felt that implant arthroplasty would not be effective, or in dealing with an index finger, then fusion of the PIP joint is a satisfactory alternative. Generally speaking, the index would be fused in approximately 25 degrees of flexion, and the middle finger 30, the ring 35, and the small 40. What I tend to do is give a patient an aluminum foam splint and ask them to mold the splint into the position that they would prefer it to be in. Some patients would prefer more flexion, others less. As far as the method of fixation, I prefer K-wires, but certainly tension bands, screws, and plates have been used. I just find that using the K-wires allows me to position the finger in the operating room and adjust it if I'm not happy either with the rotation or the amount of flexion. Lastly, the distal joint is commonly affected in osteoarthritis, causing what we know as the Heberden's Road. This again is sometimes a source of pain, but more commonly a source of complaint related to the deformity. Very commonly, patients with osteoarthritis affecting the distal joint will present with a mucus or mucoid cyst. This is a type of ganglion which emanates from the distal joint and is probably caused by an osteophyte coming from the distal joint. Sometimes these will spontaneously drain, and not uncommonly a patient will puncture the cyst itself, which unfortunately can sometimes lead to infection. A clue that a mucoid cyst exists is that there'll be a groove in the nail because the mucoid cyst is pressing upon the germinal matrix. As far as distal joint surgery is concerned, it's important to determine whether or not the symptoms are related to the arthritis or, if present, a mucoid cyst. If arthritis is the cause of the problem, then joint arthrodesis in slight flexion is usually effective in relieving pain and providing good function. Again, I prefer to use Kirschen wires. The problem with screws is that it's difficult to put the joint into slight flexion, and sometimes patients have pain where the screw has been inserted through the pulp. Tension bands have been used, but I usually find that Kirschen wire fixation alone is sufficient. In those patients undergoing surgery for the mucoid cyst, if it is coming from an osteophyte, it is important to debride these osteophytes at the time of the mucoid cyst excision. Otherwise, there will be evidence of recurrence. Skin grafting and resurfacing usually is not necessary, but if the skin has been thinned out or if there's been a recurrent infection, then a full thickness skin graft harvested from the hypothena area is an effective choice. I rarely use rotation flaps, but these have certainly been described. As far as the use of antibiotics prophylactically during surgery is concerned, I only think these are necessary if there's been a history of drainage or if there is some evidence of drainage of the cyst during the surgical preoperative period. I hope this has been of use to you, and before I close, we're going to just go through a few questions. So here, I'd like you to spend some time looking at this x-ray of this patient's thumb who has symptoms sufficient to undergo basal joint arthritis. There is some evidence of instability of the basal joint, as well as hyperextension of the empty joint, which has been measured at 60 degrees. So spend a moment looking at the options of the choices before we will go on to what I believe is the correct choice. So the correct answer, I believe, is number 4. It is important, as I previously discussed, that when doing basal joint arthroplasty, if there's instability of the base, then it may be necessary to perform a ligament reconstruction because the ligaments are incompetent. Also, in patients who have significant hyperextension, then something needs to be done to prevent recurrence of the hyperextension, and the only choice we had in this question was a fusion of the empty joint. So here's the second question, and this relates to a patient who has undergone previous surgery for basal joint arthritis, in which there has been some subsidence of the metacarpal after the trapeziectomy. And the question here is as to whether or not this degree of subsidence will have any effect on the patient's outcome. And the answer is it does not. Remember, there really is not much space between a normal articular cartilage of the metacarpal and, let's say, the trapezium. So subsidence to some degree, as mentioned in this question, really has no functional significance in terms of pain related to the metacarpal touching the scaphoid, nor evidence of loss of mobility or impairment of strength and function. And finally, number 3. This relates to a younger person who has progressive symptoms affecting the basal joint of the thumb. Examination reveals a hypermobile but tender joint, and x-rays show that there is no evidence of arthritis affecting the metacarpal trapezial joint. So if the patient requires surgery, the question is what to be done. And I would say the most common choice would be to do a ligament reconstruction as proposed by Littler and Eaton. I would suggest, however, there are some surgeons who believe that an osteotomy of the metacarpal will realign the metacarpal and diminish the laxity. And other patients, other surgeons have suggested that arthroscopy, debridement, and shrinkage will also deal effectively with the hyperlaxity. I believe, however, that the ligament reconstruction has stood the test of time and is the choice of most surgeons. Thank you very much for your kind attention, and Happy New Year. Happy Thanksgiving.